Thank you very much, Dr. Abdullah, and for the invitation. And I'd like to thank Dr. Rosano, the chair of this wonderful meeting. I'll take off my interventional hat and move to some hopefully basic science and be concentrated on cardio-oncology and heart failure. You remember the first issue of JAC, Cardio-Oncology, that's the Journal of the American College of Cardiology, was issued in November in 2019. And this is Dr. Valentin Fuster, who is the editor-in-chief of JAC. And he did ask us the question, should we call it cardio-oncology or oncocardiology? And the answer for that, no, it should be cardio-oncology, because the cardiologists always come with cards saying, get well soon, I'm the cardiologist. But look at the oncologists. They have to turn everything off. Look at their medication. Immunocheckpoint inhibitor, proteasomes inhibitors, tyrosine kinase inhibitor. They need to switch everything off. So we should call them oncologists, not oncologists. And that's why we should call it cardio-oncology. Now, the idea is, can we prevent today's cancer patients from being tomorrow's heart failure victims? Just let's get some data. And it's really encouraging data that the prognosis and survival for cancer is improving for children and for adults. And for children, more than 80% of their cancer, they survive up to 10 years. And there is increasing number of cancer survivors. Once they survive, then the risk of cardiovascular disease appear. And anthracycline and radiotherapy are the main problem or the main culprit. But there are new therapy and they have their unique problem. And the mechanism of toxicity is really not well understood. And the strategies are limited because of few data and few trials. And we need to know about the new approach, how to deal with that. Now, the effect could be an acute effect that's caused myocardial damage, arrhythmia, ischemic vascular events, coronary disease, thromboembolism, and hypertension, but we'll be concentrating on myocyte damage and acute heart failure. The chronic effect include ventricular dysfunctions with heart failure, HFrEF or HFpEF, accelerated exacerbation of atherosclerosis and increased risk of cardiovascular, cerebrovascular disease and peripheral vascular disease, and some changes on the long term of the vascular function because the medication may affect the endothelial function, some autonomic changes and deconditioning of the patient due to the therapy. Now, if you see the function of the heart, and especially of in the children, just at the beginning, they have, okay, can you see my, okay. So, is it working here? Okay, so look at the blue line in the middle, that the reduction of heart function is present directly after giving the chemotherapy. Now we reach, after stopping this chemotherapy, that the normalization of the heart function, and then a few years later, we'll get decrease in the heart function again. So apart from all those things, from the effect of the cancer for the children, we see the cardiac implication is very important. So the anthracycline induced what we call anthracycline congestive heart failure, and the incidence is 2% at 2 years, up to 5% at 5 years, and the median is around 2.8% at 6 years. There is difference between children and adults. The heart of the children is totally different from the adults because there is low incidence of acute toxicity in the children compared to the adult, minimal pre-existing cardiovascular disease compared to the adult, minimal comorbidity compared to the adult, and the latency after receiving treatment may extend to a decade or more. And myocytes are really more apt to apoptosis compared to the other, which is resistant to apoptosis. And the myocyte in the children are undergoing maturation compared to mature myocyte in the earth. So the anthracycline can cause acute toxicity. The acute toxicity is predominantly supraventricular arrhythmia. There are some risk factors and develop only in 1% or less. The early cardiotoxicity, or what we call type 1, happen within the first year of the treatment. And there is the late cardiotoxicity, which is more common, especially in the children, happen after 1 year, and the median is 7 years after the treatment. How does the anthracycline work? It's not clear understood, but there is the most important theory that the anthracycline binds to topoisomerase 2 vector, and that's when combined to this receptor, it affects the function of the mitochondria, and that really causes release of free oxygen receptor radical, and that's causes damage to the DNA, and then damage to the microfibers and get vacuolation in the muscle, and that's lead to chronic muscle damage. So the risk factor depends on the dose and the type of the anthracycline. One anthracycline is more toxic than the other. There is greater toxicity in younger people and elderly people, and this distinctive mechanism between those two things. And the main thing is accumulation of free radicals, and that's causes myocardial damage. So greater toxicity risk in the presence of other conventional risk factor. Look at that. If the patient has hypertension to start with, the incidence of cardiotoxicity goes 1.5. Coronary artery disease exceed doubling. Age more than 55, more doubling. If you have 3 risk factor, it's 5 to 6 times. So, and in women, dominate after treatment for breast cancer after 7 years. And if there is cardiovascular risk factor in those ladies, that doubles their risk to develop cardiotoxicity. Now, also the combination of chemotherapy for the breast cancer is an important thing. So let's concentrate on that. If we give anthracycline alone, is the incidence around 4.3% at 5 years. Now, most of the breast cancer receive Herceptin or HRER2 receptor antagonist, and that's caused them to develop cardiotoxicity around 12%, because really when we give that, we are preventing the action of HER2 receptor, which is protective for the heart. Once we block this receptor, we will get more damage, especially if the patient is receiving anthracycline. So if the patient receiving combination, the risk of developing cardiac toxicity goes up to 20%. So the importance of combination chemotherapy for breast cancer is very we need to keep it in mind and assess the patient whether they are at risk of developing. So we talked about dose dependent and the mode of administration. Instead of giving bolus, that's cause release, a quick accumulation of oxygen-free radicals, it's better to give the medication as continuous infusion. And as we said, the children and the elderly are more prone, and there is overlap between the cardiotoxicity effect and the anti-tumor effect of this medication. So in summary, cardiomyocyte damage are mediated, especially in the anthracycline, through the activation of free oxygen radical product, mitochondrial dysfunction, and DNA damage. And this acute changes induce apoptosis, and that's mediate the effect of acute cardiac toxicity. But what's the mechanism for long-term or late acute cardiac toxicity? Is probably just the accumulation of those toxic substances inside the myocardium. So we concentrated on the anthracycline, but there are a lot of medication that we use in the chemotherapy, and I don't have the time to go through that. So I'll concentrate on a couple. Let's concentrate on monoclonal tyrosine kinase inhibitor, whether it's real antibody or small molecules. And if you review the side effects and really what the FDA is putting warning that all of them, most of them cause hypertension, and a lot of them cause arterial thromboembolic events, and a lot of them cause cardiac dysfunction. So why are we using those medications? Well, the reason for that, look at this. In a patient with chronic myeloid leukemia, before using those medications, the conventional therapy, the survival rate only 15% at 18 months. But when we use this medication like imatinib, look at the survival rate, 89% at 18 months. So we are converting this deadly disease into a chronic disease or curable disease. So I'll skip the idea on pulmonary hypertension since we don't have time. So I gave you about the tyrosine kinase inhibitor. Let's talk about immunotherapy. The immunotherapy is the immunocheckpoint inhibitor. And there is nivolumab and ipilimumab. Those are common combination drugs. And those cause really like great revolution in the treatment of some cancer. Look at this cancer. This is metastatic melanoma. And without using this treatment, the survival rate is only 15%. But when we use this medication, the survival rate is around 60%. And everyone should remember President Jimmy Carter. You know, President Jimmy Carter, he is from the Democratic Party. He won the presidency against Gerald Ford in 1976. And he has metastatic melanoma, and he was treated with that. And although he did have metastasis to the brain and the liver, and he reached full cure, and he's still alive at the age of 96 till now. And now it's this medication caused a lot of side effects outside the heart, like colitis, pneumonitis, and myocarditis is really low incidence. It's 1%, but unfortunately, the mortality rate is around 50% in this disease. Once we get myocarditis in this, its fatality rate is very high. So let me give you an explanatory case. This is a 56-year-old woman, a metastatic Merkel cell carcinoma, treated with carboplatinum and did not improve, and then switched to the combination of this immunocheckpoints inhibitor. And after 2 cycles, she developed fatigue, myalgia, some pain in the hip and the thigh. There were some elevation in the troponin, and the CMR showed normal left ventricular ejection fraction and suggestion of myocarditis. Look at her troponin level. At the beginning is really very high. And she received steroids at high dose, did not improve, received anti-macrophenolate, and did not improve, received tacrolimus, and at that time did improve, and she improved significantly, and look, the troponin went back to normal. So she has significant risk of sudden cardiac death. The symptoms with this kind of myocarditis is positive symptoms. The patient may develop just fatigue, chest pain, and they respond to high dose of steroids, and she continued to do well. So this is the idea of checkpoints myocarditis. I'm going to skip that and concentrate on the prevention. Every patient who received that without risk factor, we consider that at risk or stage A heart failure, and then we may give some medication. The medication to protect anthracycline cardiotoxicity, only one medication is dexrazoxane, and to prevent as you said, the interaction with topoisomerase 2 beta and prevent the direct effect of the toxicity on the cardiac muscle. And it is there is strong data for that, but unfortunately, it's only approved for the treatment of metastatic breast cancer. Can we get an extra minute? This is the. Okay, so it's really approved only for metastatic breast cancer, but there is a lot of data. If we use it early, we can prevent cardiotoxicity. Using of statin also prevent the accumulation of toxic substance, and there are some few data for that. Using exercise also prevent the development of cardiotoxicity, and this is some data in the children. And if we do that early and there is dose response, the more exercise the patient is doing, the less cardiac toxicity. So how do we monitor that? There is a lot of things you can monitor with troponin, but to concentrate on the ejection fraction just by echo is not adequate. So GLS may be more sensitive to detect cardiac dysfunction. So, starting treatment for preventing heart failure as early as possible using ACE inhibitor or beta blocker. There is no data for the SGLT2 inhibitor. So, and there is only few data, scattered data, 16 study, but small number, showing that you may get improvement. So in conclusion, there are this area of cardio-oncology treatment is still far from the limit. And we need to do ad hoc. We cannot do ad hoc that just when we see the patient, we start any kind of therapy for heart failure. It requires really a close relationship with our oncology colleagues and apply what we know the data for every by individual cases to put the plan. And there is a lot of cases you can use all of those medication. If I can move to radiation-induced heart disease, there is, it may affect the macro vessel, the micro vessel, and the valve, and cause to heart failure. And with that, give me 1 minute.
Okay. 30 seconds.
30 seconds. So the radiation is depending on the dose and the area that's exposed. The tumor location, whether we are irradiating the chest or the whole heart, and with according to the age, and whether we are using anthracycline and the presence of other risk factor or established cardiovascular disease, and it may last after 10 years of radiation. So let me present this is a new case. Everybody talking about CAR therapy. Well, I covered the main points.
Thank you very much. Excellent.